All right, I'm back. So, we were talking about the culturally competent care. When we talk about physiological characteristics of different races, we think about different races and ethnic groups that are more prone to develop specific diseases. Some of the examples they gave you in the book are um, the idea of Tay-Sachs disease and its association with individuals of Eastern European and Jewish descent. Although the incidence of this disorder has declined over the years because we have improved early testing and assessments, it is still a concern. And it kind of gave you a really good table on page 27 to show you what they were talking about, different common health problems in specific populations. So there are physiological variations that we see in different populations. Yes, we see a lot more sickle cell anemia in African Americans than we do in anybody else. We can also usually say that we see more sickle cell anemia in men versus women. So we see different physiological characteristics in different races. We do have to take that into consideration. We also have to take into consideration when providing culturally competent care is people's reaction to pain. Now, we need to recognize that culture is an important component of individuality, that each person holds and has the right to hold various beliefs about pain. I'm sure we in this class don't all hold the same thought about pain as everybody else. I, for one, really liked my anesthesia that I got for delivering my babies, but there are other people out there that probably can deliver a baby with no anesthesia. We all have different reactions to pain, but we have to respect the patient's right to respond to pain in whatever manner is culturally and individually appropriate. Never stereotype a patient's perception of response to pain based on the person's culture. And you will see that a lot in the hospital. I saw that on labor and delivery a lot. People didn't want a certain woman who was delivering a baby because she was of a different background. And they had had a woman like that before and knew how they were going to react to pain. What would we call that then? Would we call that stereotyping? Definitely. So I saw a lot of stereotyping when it came to taking on patients on labor and delivery because they didn't want to deal with those patients. They had already dealt with that type of patients and they didn't want to deal with that at all. Very, very bad stereotyping going on when it comes to pain. Okay. What about mental health? Mental health is really something that's dealt with very different in different cultures. It may be appropriate to go to see a psychiatrist or psychologist in some cultures and very inappropriate in other cultures. So we do need to be aware of that, especially when we're asking questions. This is a big reason why, especially with mental health or anything else that's pretty sensitive in healthcare, that we use interpreters. I believe we'll be talking about that a little bit more in this 15-minute video clip, but it is really important not to use family members as interpreters. Now, having said this, I have used family members in a pinch, especially at night, if they were there to ask questions. But I did not use them to ask questions about pain, and I didn't use them to teach when it came to discharge time. That's quite a bit of information, and plus they may not really understand the verbalizing that I'm trying to get across. They don't know medical terminology possibly. They might not have a background in that. So I want somebody that has a background in medical terminology to be the interpreter for this client. It's best for the client and as well as for me to get the education across that I need to get across. So I am very pro interpreter. It's pretty neat what they're doing in the hospitals these days with interpreters. They don't actually have to be there. We can now Skype interpreters. I've seen that done with iPads. Phone, of course, you can use a phone interpreter, but all of these can be 24/7. So it's pretty rare where we don't have somebody that we can use as an interpreter. Okay. But it's also pretty nice to know another language. Spanish has always been the language everybody was very happy if they knew Spanish because There seems to be a very high Spanish population, especially in Wisconsin. So if you're going to be nursing here, you will see a pretty high level of Hispanic population, and speaking Spanish can be very helpful. A friend of mine immersed herself down in South America and learned Spanish, and then when she is now a nurse in Madison, she has used her Spanish quite a bit. It has been great help for her. But if you are not fluent in a language, you do have interpreters at your fingertips. Okay, gender roles, if we're going to talk about that, we do need to talk about that. In many cultures, the man is the dominant figure and generally makes decisions for all family members. I've seen this quite a bit in working in labor and delivery, where the man is making a lot of the decisions, even though it's the female who's going through a lot of the health care. As much as I have found myself thinking, oh, that's so wrong. She's the one who I'm dealing with. Why is he answering the questions? It's not wrong. It's what their culture it says is how they should react to these things. So, knowing this, I was able to communicate to her, possibly through her husband, through a father figure. But the man is the dominant figure in some of these different cultural backgrounds, and we need to work with that if we want to get the education across that we need to, and if we want to find out how their pain is. I was always amazed when I would ask her pain, and he would give me the number on a scale of 1 to 10. But that has happened. In other cultures, the woman is the dominant figure. And a lot of times I have to say in labor and delivery, the woman has been the dominant figure and has been able to express her concerns herself. But I have been in the position where the man was the dominant figure and he would answer the questions. So knowing who the dominant member of the family is important when planning nursing care. And especially it comes into play if that dominant figure is ill, because it seems like the family or extended family can break apart if that dominant figure is sick because they're not exactly sure how to deal with it. I saw this when I was teaching last semester when the head of the family got very ill, and they would come in and visit them, but they weren't exactly sure what they were going to do. Language and communication, we kind of talked about that. Try not to use a family member as your interpreter. Try not to use another worker on the floor, possibly, that does not know medical terminology as your interpreter. Sometimes in a pinch we have done that, but I don't like to ask any sensitive questions or do any education with somebody who doesn't have a medical terminology background. We need to be aware of orientation to space and time. So what does that mean? That's our personal space. Anybody ever seen the Jerry Seinfeld show in which they had the close talker? The person got right into their personal space. It was a really funny show, but it's true. We tend to have a wider personal space around us than, say, a different culture might. So once again, I'm going back to my labor and delivery. I had to really get into their space to take care of them. And in healthcare, we tend to do that. So we need to be aware if this is an issue with our clients. Food and nutrition is very important. If they need a special diet, if they like food a certain way, we need to be aware of this. And usually we're seeing that in our assessments as they're coming in and we are admitting them. But it doesn't always get taken care of. So we need to be sensitive about the fact that they may not eat the same kind of foods or the foods that are on the menu in the cafeteria. We also have to be aware of family support being very important in a lot of cultures, especially even in our culture, family support is very important. We need to have respect for the elders in the family and never consider institutional care. I'm sorry, I take that back. There are lots of cultures who don't believe in institutional care, and here we are all doing our clinicals at nursing homes. So nursing homes may not even be in different areas of the world because people take care of their elders at home. They would never think of putting them into a nursing home, but they may have trouble caring for them. So are they getting the best care? Like the people that are getting their care at a nursing home. So we have to think about those things. And then also socioeconomic factors come into play. We're seeing that a lot more in patients coming in with no insurance, and now we have Obamacare. but we still are dealing with plenty of clients who don't have insurance and who need the care. And they don't have insurance because they don't have the jobs. And so if they don't have jobs, they don't have the money for the insurance, or they don't have the chance to have insurance. So we're looking at lots of different socioeconomic factors when it comes to our clients. We need to know how to deal with those. We need to deal with them culturally. So our culturally sensitive nursing care, patient in pain, we kind of talked about that. I went through all of these, never stereotyping the patient just because of how they deal with pain. And the culture of poverty, the socioeconomic status. There's a feeling of despair and day-to-day attitude toward life. Unemployment is high, so need for financial or government aid is out there. You will see a lot of stereotyping when it comes to socioeconomic status. You will hear about people saying, well, they didn't have insurance, but they sure could afford their cigarettes, or they sure could afford their beautiful manicured nails. I wish I could afford that. And you don't know the whole story behind everything. As much as you feel angry about that, you don't know the whole story. And your job is to give them good health care. Also, the unstable family structure and the decline in the self-respect and retreat from community involvement. Care must be sensitive to the needs of the individual. So really, the number one thing we have to remember in culturally competent nursing care is that we treat everyone as an individual. Okay, we need to understand that yes, they may be part of a cultural group or an ethnic group, and that they may have different nutrition needs, but we also have to realize that everybody is an individual. We can't lump them all together and stereotype everybody in a certain ethnic group. So treating everybody as an individual is very important while still continuing to be culturally sensitive. The healthcare system is a culture with customs, rules, values, and language of our own. We are our own culture in healthcare. And that's why when I say use an interpreter as a medical terminology background, that's why it is so important, because we are a different culture. We have our own language. And nursing is the largest subculture of the healthcare system. You are becoming a majority group in our healthcare system. We are more than the physicians. We are more than the physician assistants. So nursing has a large voice out there, but we also have to provide a very good, culturally competent care as nurses, or we look as ignorant as everybody else. Factors that affect culturally diverse interactions is the cultural background of each participant, expectations and belief of each person about healthcare, cultural context of the encounter, and degree of agreement between the two persons' sets of beliefs and values. We don't have to agree with everything that our clients do, but we do have to respect our clients' health care. That is what we're out there to do. We may not agree with everything that they do, but we do have to give them the good health care that we promise to provide as we become nurses. Expectations and belief of each person about healthcare. We all have different expectations and belief, but the one thing we do believe in is that everybody deserves good health care. All right, guidelines for providing culturally competent nursing care. You need to develop cultural self-awareness. How do we do that? So one of the things we can do is we can read about different cultures. We can immerse ourselves in cultures, go on cultural trips, which I think is the best way to learn and become more aware of different cultures. Develop cultural knowledge, accommodate cultural practices in healthcare. Ask your patients, hey, why do you have these prayer cards? What do these mean? A lot of times they're happy to share that with you. And respect cultural-based family roles. Avoid mandating changes and seek cultural assistance. Together, we can provide great culturally competent health care. Well, I know this was a different way to learn, a lot faster than sitting in class and listening to me talk. But we didn't have as much to cover. Culture is huge. It's much more than the chapter that I asked you to read, and you'll be learning this as you go along as nurses. But you will see a lot of stereotyping, a lot of ethnocentrism that you do need to try to avoid to be good culturally competent nurses. I hope you guys have a great weekend. Don't forget to take your test, and I will see you in 2 weeks. Next week, you'll be getting the same type of lecture. Thanks, guys. See you later.